This is chest imaging 10 prepared by Prof. Sharaf and revised by Prof. Yusriya. It will be about chest wall. Multiple myeloma, for example, is one of the most common hematopoietic neoplasms of the chest wall skeleton. It appears as multiple or solitary expansile lytic lesions of bones, and of course you cannot distinguish multiple myeloma, metastatic carcinoma, or severe osteoporosis. The three can mix. Neurofibromatosis is another entity in which we can have CNS neuromas and cafe au lait spots and small superficial tumors, neuromas, kyphoscoliosis, posterior vertebral scalloping, paraspinal and mediastinal neurofibromas, lateral meningoceles, ribble ribs, interstitial fibrosis, and bullous lung. Here you find wide intervertebral foramina with CNS, multiple CNS neuromas. What is this? Chest wall. There is something abnormal. It is a continuous line of calcification along the anterior spinal ligament due to ankylosing spondylitis. Here you find 1, 2, 3, 1, 2, 3, multiple enchondromata, expansile calcific lesions within some of the ribs and at the left scapula. And this is Maffucci syndrome. Maffucci syndrome. The differential diagnosis is fibrous dysplasia. Soft tissue masses of the chest wall may be neoplastic, whether benign or malignant. We can have lipoma or neurofibroma or desmoid tumor. Each one of these can present either with normal rib or pressure erosion on a rib appearing eroded, or there may be destruction of the rib as in fibrosarcoma, chondrosarcoma, multiple myeloma, metastatic deposits. Again, soft tissue masses of the chest wall may be inflammatory or traumatic, as hematoma, for example, abscess, myositis ossificans. All these conditions can involve the chest wall. What are the non-neoplastic chest wall masses? You know, non-neoplastic. So we'll exclude from above down the neurofibromas, the lipomas, and fibrosarcomas, chondrosarcomas, multiple myelomas, metastases. It may be inflammatory or traumatic. Maybe inflammatory or traumatic. Name 5 neoplasms of chest wall. You start with again benign, lipoma, neurofibroma, and desmoid, chondrosarcoma, fibrosarcoma, multiple myeloma, and deposits. These are malignant and these are benign. The most common is lipoma, and the most common are the malignant, whether primary or multiple myeloma or metastatic disease. Now here we have mass involving outside and inside along the rib with dense fading shadows inside and this is due to hematoma. So trauma of the chest wall may result in hematoma, and there is associated lung ataraxis and contusion, chest wall mass bulging left pectoralis and onto the left hemithorax. The differential diagnosis is an abscess or tumor, and here we notice that there is still fresh blood seen, and this may need embolization of the intercostal artery. Another case of multiple contiguous fractures. Multiple healed fractures suggest chronic alcoholism or an accident. Those with multiple fractures are usually, here is one, here is two, usually chronic alcoholic or is due to an accident. A pathological refraction may be a feature of metabolic or neoplastic disease, for example hyperparathyroidism, multiple myeloma deposits, etc. Acute rib fracture. If you have acute rib fracture, search for, of course, pneumothorax, hemothorax, or pulmonary contusion or laceration. So if you have something traumatic, you should exclude involved lung as contusion or laceration, involved pleura as hemothorax or pneumothorax. Fracture of the 10th, 11, and 12th strips may be associated with injury of liver or spleen accordingly. Healing currents will be exuberant in patients who are receiving corticosteroids. So again, multiple rib fractures could be pathological, could be post-traumatic. Multiple rib fractures result in what we call the flail chest. It is multiple contiguous rib fractures. If it is something chronic, you should suggest an old trauma or chronic alcoholism. If it is pathologic, please exclude hyperpara and multiple myeloma. In acute fractures, exclude lung laceration and pneumothorax. Fractures of the lower 3 ribs is usually associated with lesions of liver or spleen accordingly. Why sometimes there is exuberant callus? This is seen in patients receiving corticosteroids. Extrapulmonary mass with pleural, extrapleural, homogeneous, broad-based soft tissue. Imaging 3 and 4 after 3 years. 3 and 4 after 3 years. The long chronic history suggests that it is something which is not aggressive, and amongst the tumors of the pleura and ribs, chest wall, we have the lipoma, and the density is not like that, and the extension would not be like that. We have the mesothelioma, and of course it will not wait for 3 years. Neurofibromas will not extend, but that one extending is usually fibrous tumors. Fibrous tumors are long-standing and spreading. Chest wall masses include infection, abscess, tumor, and here we have the benign and the malignant forms, and trauma. And don't forget that in trauma there is something called flail chest, and there are involved, if the 11th, 12th, 10th, 11th, and 12th strips are involved, please search for liver and splenic injury. So fibrous tumors are one of the again known tumors of the chest wall, long-standing and extending. Here we have 1, 2, 3. Density is that of fat. There are multiple sharply defined low density intermuscular masses. Of course, lipoma is the most common, as we said before. Lipoma may be subcutaneous, may be intramuscular, may be extrapleural. Also consider the two famous lesions of the pleura, the fibroma and the neurofibroma, but the density here is that of fat. Now we have mass here, something soft tissue here, and this soft tissue has some calcifications with bone destruction and extension inside, and we are left with something malignant, chondrosarcoma, pleural deposits, or multiple myeloma. But in multiple myeloma, we expect that the bones are involved. Here the soft tissues are more involved. And in pleural deposits, usually there is no such dense calcifications. Chondrosarcoma is one of the famous primary tumors, most common primary tumors of the thoracic cage, following the intraosseous multiple myelomas. So multiple myelomas is intraosseous, while chondrosarcoma is paraosseous, or coming from bone, but it does not necessarily expand the bone. So what is the most common primary chest malignancy in adults? It is the chondrosarcoma. Here we have heterogeneous calcification, rib and vertebral destruction, and extradural extension into the spinal canal. Don't forget that we have a category of osteomyelitis, and of course in osteomyelitis the bones are not in this way, and are involved not in this way, because bones are definitely will show signs of inflammatory process, means irregular erosion, destruction, and irregular new bone formation. Large mass with extension in and out, large soft tissue mass. Of course, amongst the differential diagnosis is deposit, but as we said, if the bones are involved in expansion, don't forget multiple myeloma. Lymphoma could be, and fibrosarcoma is another possibility. So the most common cause of secondary tumors is secondary, deposits, and the most common primary is the chondrosarcoma. Now here we have multiple nodules along pleural lines, here you have evidence of something encasing. Here we have multiple pleural lesions extending around into the recesses, multiple pleural lesions. These are the appearance of pleural metastasis if it is involving fissures. It could be due to breast, it could be due to thymus, it could be due to any, but This is appearance of fissural pleural deposits. Fissural pleural deposits. Pleural encasement. Here fissural, here is fissural, and here it is encasing. It's typical appearance of pleural deposits. Multiple masses of the pleura, multiple nodules associated with pleural effusion. Of course, first possibility will be mesothelioma, but there is something here, and left parenchyma, basal parenchyma changes, and there is a history of ovarian carcinoma. So these are deposits. So mesothelioma, consider with it the pleural deposits also. Here a collapsed lung, a opacified right lung with radiolucency around and intestinal shift to the other side. This is tension pneumothorax, and in the left lung there is ground glass appearance. We have collapsed, opacified right lung with air around and shift of the heart and mediastinum to the left. This is tension pneumothorax in a case of ARDS. Tension pneumothorax, you find the heart shifted to the other side, and this is the air seen anterior to the partially collapsed lung, and here it is shift of the heart to the other side, and here it is delineated with markedly depressed diaphragm. So if you find shift of the heart and mediastinum with downward shift of the depression of the diaphragm, please consider pneumothorax of the tension type. Tension type. Of course, any large pneumothorax will cause shift, but in tension pneumothorax, the depression of the diaphragm is characteristic. Depression of the diaphragm, depression of the diaphragm, depression of the diaphragm. Pneumothorax is abnormal collection of air, maybe spontaneous or traumatic. Signs, of course, we can find sharp intestinal margin, hypertranslucent chest, deep costophrenic sulcus, double diaphragm signs, simultaneous visualization of the anterior costophrenic sinus outlined with air, and the diaphragmatic dome outlined with the lower pole. Pneumothorax may be related to abscess, histiocytosis, apodosis, cystitis carinii, pneumonias, or Colles disease. Any of these can cause pneumothorax, and we have just seen cases of tension pneumothorax and a case of tension pneumothorax in an ARDS, acute adult respiratory distress syndrome. Pneumothorax in supine position, of course, air will collect anterior while the fluid collects posteriorly if there. Lucency over the upper abdomen. Deep costophrenic sulcus, double diaphragm sign, visualization of the anterior and hump at the same time. Medial lucency outline the mediastinum, outlining the mediastinum. This is lucency mediastinum, lucent mediastinum. This is double diaphragm 1 and 2. This is anterior recess. This is the copula, and there is increased translucency, which may extend into the lower abdomen, and so on. cardiomyopathy, and here there is bilateral pneumothorax, but don't forget that there are something called skin folds. Skin folds over the apices extends beyond the basis, coming outside and not limiting vessels, and there are multiple skin folds. Of course, this may in infancy may cause some difficulty. Diffuse pleural thickening, it may be smooth as in empyema or asbestosis, so it usually represents pleural fibrosis of infection or collagen vascular, also exposure as in asbestos, or it may be lobulated as mesothelioma deposits and multiple empyema. Thank you.